Welcome to That's Derm Good. I'm Janelle Ball, and I'm excited to bring you thought-provoking conversations about biologics, specialty medications, treatments, and so much more. I'll be chatting with some amazing guests about access, affordability, and advocacy. You're really going to enjoy this show. Welcome to That's Derm Good. Today, my guest is Obehi Oriaifo. Obehi is a dermatology NP, and I am so excited to have you join That's Derm Good.
Thank you, Obehi Oriaifo. I'm a dermatology certified nurse practitioner.
Okay.
Yes. So usually different in training because I did go to nursing school and then
Mhm.
went for my nurse practitioner and got certified as a dermatology nurse practitioner.
Oh, okay.
Yes.
So,
Yeah.
how did you get into the dermatology space in the first place? What sparked your interest into the medical field first, and then specifically into dermatology?
Yes. So actually, I grew up in Nigeria, Benin City to be exact. I grew up watching my dad. He actually ran a non-governmental organization. So like it saves accident victims. He had some organizations actually donate ambulances to him. But I do remember even driving to school, it would like pick up accident victims in his car and drive them to the ER while I'm right there in my uniform. So, I mean, just watching that form of service kind of excited me. I was like, okay, I kind of want to go into the medical field. So, I actually started my nursing career in the ER. So, I was in ER for about 7 years. And then when I started my clinical rotation after deciding to go back to nurse practitioner school, I started to see dermatological conditions that is beyond the surface. It's actually like immunology in action. So it tells us what's going on in the inside rather than what we see on the surface. And that actually fascinated me. So I was like, okay, I think this is where I want to be. Well, funny enough, I was trying to get away from the ER and seeing blood and all that stuff. Funny enough, dermatology is almost is quite similar because you're still doing all the procedures and all the
Mhm.
hands-on stuff. But I mean that keeps it exciting, I guess.
Right.
Yeah.
It's funny. I'm like, yeah, as a young kid, you are seeing that a lot. You're seeing quite a bit of things if you're in the car, helping picking up people and taking them to the hospital.
Mm,
You learn a lot. So that makes sense that, you would wanna be in the healthcare industry.
yeah. Even after school, we'll go wait for my dad in his office, and it was right in the middle of the ER.
I love that. Hands-on training.
Yeah, hands on. Started early, started young.
This is what you know what you're gonna do. This is it. I
Yeah.
love that how you describe dermatology as immunology in action. Can you break that down for us in real life term?
Sure. I mean, dermatology in action, pretty much, the skin is not just a protective barrier. You have like active immune cells that like interact with each other and protect that skin barrier in terms of even looking at disease conditions like psoriasis, eczema. They're all driven by immune markers, what we call cytokines. So even in eczema, we have like the IL-4, IL-13 that drives the type 2 inflammation. In psoriasis, we have the IL-17s and the IL-23s. So that's why now that we're coming with better medications to help these conditions, we're targeting that specific immune marker. We're not just going full blast and, working on all the immune cells that are involved. So immunology in action is pretty much, these are the specific cytokines that actually drive this inflammation. And that's what dermatology is about because any new medications that come out now is targeting those cytokines.
Wow.
Yeah.
So it makes it so that there's so many more options for patients
Yeah.
now than there used to be. How does that kinda change how you prescribe or when people are still wanting to have some of the medications that they've been on in the past? How do you explain it to patients when you say, "Hey, there's something new?" Because I feel like sometimes people get a little nervous when they're like, "This is newer mechanism of action," or "This works differently." than
Mhm.
some of your older medications that you've been on for years in the past. How do you explain that to patients?
I think the first thing I like to explain is yes, these medications have been present for years, almost like when we started with the new antibiotic, penicillin. That's pretty much what we knew. But now we have new generation of antibiotics. So being more specific, targeting the actual bacteria that it's going to work on. So pretty much that's how any biologic or medication that we're using to treat a specific disease should work. If a patient is on steroids for a long period of time, let's say I have patients that will say, oh, they come to me newly, like, I've been on this steroid for 10 years. Do they understand the risk factors involved with being on topical steroids for that long, which includes glaucoma, even risk for systemic absorption? It can even put you at risk for osteoporosis. And using it sparingly, let's say twice a week, pretty much will um, reduce that risk, but it's not without risk, right? Most of the medications that we're using do have the risk involved with them. So I do explain that risk to them and I tell them there are newer therapies that actually are more specific. So rather than working on your entire inflammatory markers, we're actually targeting the ones that are driving these inflammation and helping, and actually they do work better. So I always show them pictures too, because I feel like most of our dermatology is a visual field. So I always show them pictures. Even the websites of the medications sometimes have good visual presentation. So you go in there, you can see how they can look like in 6 weeks or 8 weeks. And that kind of puts things into perspective for them. Mostly when they come in and they haven't been cleared on a certain medication. And also, it could also be insurance barriers as well. So, insurance will want you to try a certain medication first before you go to the biologics. So, usually, I have my patients on steroids. I tell them, well, if I'm treating like eczema, I want you to use it 2 weeks on, 1 week off. If you have a flare up, then you can use it. So kind of use it sparingly. But if it's not under control, we should be thinking about the next step. Non-steroidal medications like the topical calci-urine inhibitors, such as the tacrolimus. So we should be thinking about the next step. And then even at that next step, because that's usually the hurdles the insurance wants you to go through, even after the next step, you should be telling them, okay, if this is not well controlled, because I also don't want you to be on this medication forever. They're actually long term maintenance medications that can be used to control your disease. So, I mean, it's just having that conversation with them and say, okay, these are things that we can go through. And
Yeah.
yeah.
Do you think of the insurance barriers, does that determine what you write, or do you feel like, "Okay, I already know what they're expecting, so I'm kinda gonna go in that route first," and then or are you usually like, "You know what? This is what I want, and this is what we're gonna try and get."
Yeah. I mean, most of the times the insurance company will try to dictate what you prescribe, but that's why we have appeals. That's why we have you can write the prior authorization. You can give your rationale on why you're going to this medication. And specifically, when I'm treating psoriasis, I do ask for other comorbidities like joint pain, even inflammatory bowel disease. Those can drive exactly where you want to choose your biologics. Do you want to go to an IL-17 in someone with an active bowel disease? No. I mean, that's going to probably flare up their disease condition. So then you're thinking about other medications like IL-23s that could probably help with that. Even with comorbidities like arthritis, sometimes the TNFs could work for that too. So I mean, that just determines where exactly we go, and that's why I said pills are great. So even if your insurance is telling you this is the one we're paying for, we can probably say this is other comorbidities that you're dealing with, and this will not be the best option, and just help guide your care pretty much.
Yeah. So one of the things that I feel like I hear a lot with patients is that the biologics actually suppress the immune system.
Mhm.
How can you describe that or explain that to people just so they understand how that works? And a lot of times patients are afraid to start a biologic because they feel like, oh, this is going to cause depression or this is going to cause all these other issues if I take this because it's going to suppress my immune system.
So, I mean, we have to look at the research. So even the research has shown when you put those on the medication and those without the medications are pretty much comparable in terms of depression, depending on the medication that they are on. In terms of cancer, I mean, TNF does have that risk of cancers like lymphomas, but usually they were used in conjunction with other immunosuppressants, let's say methotrexate and cyclosporine. So they were not used alone. So most of the time, I don't use these medications in combination. I'm either using one or the other. And technically, you should not be on cyclosporin for a long period of time. It's usually for like a short period if needed. But in terms of cancer risk, it is very rare. It is usually in combination with other immunosuppressive drugs that they found risk for lymphomas. And even with the newer medications like the IL-17 and the IL-23, that risk is not there. But I always tell people you're at risk for even skin cancer. You're probably at risk for skin cancer even with psoriasis because it's an inflammatory skin condition. And anything that affects your skin barrier always also puts you at risk for skin cancer because you're more likely to have damage from the sun. So that's why I say scars are more likely to get skin cancer because it's damage from the sun. So if you have an active inflammation in your skin, you're more likely to get UV damage in that area. So sun protection is very important as well while you're on this biologics. So I think it's more the disease condition that puts you more at risk for that than the actual medication in terms of reducing your or causing more infection rate. But one thing I do check for all patients, depending on whatever biologic there is, a TB test. So a TB test is a must that I do check because it can probably reactivate a latent TB into an active TB in terms of infection. Those are the usual things that I check is a TB test in all biologics. Then, of course, we're checking CBC, CMP, depending on the biologic that we're using as well. Yeah.
Yeah. What do you think has changed the most in dermatology over the last few years when it comes to understanding disease?
In understanding disease, it goes back to all this immune pathways because I mean, before, as I said, we just use the steroids. They're not because since I started my practice in dermatology, there were so many biologics that came out, and I'm like, geez, another one, but it's good because now they're even specific, and it's also towards the patient's need because we have biologics most of the time that are injections. There's actually a new biologic now for psoriasis, the IL-23s, that's actually an oral pill that just got approved. So, I mean, patients who are have a fear of needles can actually benefit from that therapy as well. So you don't have to go into the injections if you don't want to because there are other options now available. I mean, those were not available then. It's either you slap the steroid on or now you get the shots. So now there are options for even the pills that you can do for your psoriasis, even JAK inhibitors, which actually work inside the cell. So I mean, there are JAK inhibitors also for alopecia areata, which is actually one of the skin diseases that I actually do relate to more because I grew up in a family where my mom, my grandmother all suffered from like hair loss. And growing up, I was like trying to figure out, okay, what is this? And even in our culture, they link it more into like witchcraft or poor hair care and not really understanding the immunology towards it. Because our hair actually has what we call, they are hidden from our immune cells. Okay. So, which means they have the immune privilege. Our immune system can't attack our hair. So that's how it's able to grow. So in alopecia areata, now your hair becomes more visible to this immune markers, and now your hair is falling off in circular patches. And now there are specific medications to treat that, right? The JAK, the TYK2, the baricitinib, Olumiant, the rituximab. So all these medications, I'm like, okay. And when I was doing my clinical rotation, I saw this. I was like, well, this is a disease that I grew up knowing it probably has no cure. There was no hope, pretty much. So seeing all those, I'm like, oh, there's actually hope here. There's actually research being done to address this condition. I mean, that sat with me during my clinicals. And mostly in our Black community, our hair is linked to, our identity, is linked to our wellness, and just seeing how these newer medications can actually improve that sense of being. Just, yeah, it was actually what drove me more into dermatology during my clinical rotation. Yeah. So.
Yeah, I mean, it could be so powerful to be able to see where there was nothing, there were, and you're just learning about it and growing up seeing that. Now seeing that there's so many, I mean, there's multiple things now available for for alopecia, and I feel like it's actually just within the last few years has started becoming like, creating more awareness around
Yeah.
it, and people will started saying, "I actually have alopecia," and are able to confidently say, "This is something that I'm struggling with," and I think that is huge because that is not something that you typically would wanna share with people and say, "Oh, yeah, guess what I'm struggling with," and everybody would be like, "You've never heard of that before. What are you talking about?"
Solicited advice like, oh, have you tried this oil? Have you tried this hair growth serum? It's like,
There's so many people that are struggling with it and maybe didn't even know that's what it was. So now that there is so much more education, do you think that people should learn more about the immune pathways when it comes to the skin? And do you even see that happening now for patients or just general people that don't have that awareness?
yeah, definitely. I mean, you want to know what's causing your disease condition. You want to know the why. And knowing the why is how we treat it. Because we're not just walking into the room and say, "Okay, I don't know what this is, but I'm just gonna slap this med on." I mean, we're knowing exactly what's driving this. I mean, there's so many conferences now that talk about these medications. There's so many reps that go around and even educating staff about what immune pathways the specific medication is working on or blocking. So, I mean, the education is there. There's so many platforms that people can go and learn about these cytokines that are actually driving the disease condition. So, yes, I do see that being helpful because you want to know exactly what's causing that disease for sure.
Yeah. What what do you think um is something that more providers understood about the emotional side of skin disease.
Well, yeah, there's definitely emotional side of skin disease. I mean, a good example I even give with that is a nodule, what I usually call a nodular form of eczema is prurigo nodularis. There are certain markers, the IL-31, that's actually itch driven, can actually infect the nerve in your skin and cause that intense itch. And now there are newer medications just targeting that IL-31 in terms of helping that itch symptoms to be subsided. So yeah, definitely these medications are there, and knowing that these certain markers are what's driving it is like, okay, that's what I'm gonna be working on, right?
What do you wish that more providers understood about the emotional side?
Okay, the emotional side. I mean, you don't want to have a disease condition where people tell you, oh, it's chronic.
Mhm.
There is no cure. I mean, that alone just puts people in a state of depression or no hope. I mean, our job is actually to instill some sort of hope in our patients. I mean, most of dermatology conditions are chronic, yes. But are they manageable? Yes. They're very much manageable with these newer medications. So instilling hope, telling them, I'm here for you. We're going to walk through this process together. If this med is not the right one for you, there are other options that we can try as well. And I'm also here to guide therapy. I'm here to monitor your labs. So if there's anything that goes a wire in your labs, I can step back and say, hey, we can hold this medication and assess from there. So most people tend to worry about the future side effects, but I'm like, you're dealing with an active inflammation right now. And even psoriasis on its own can put you at risk for other inflammatory diseases, cardiovascular diseases. So if you're not even controlling your psoriasis because you're scared of what may or may not happen, in terms of the low risk of possible cancer, the low risk of possible infection. I mean, you putting yourself at risk for even greater stuff that actually proven to happen. So I tell people focus on the now, and the now is treating this disease condition, controlling this inflammation. That's why you have a healthcare provider. We are going to monitor you. So I always have my patients on biology, depending on the ones. They come back in 4 weeks. We probably check labs again if it's a TNF. And then in 3 months, I check labs again. And if everything is fine, we can probably say 6 months. But you are actually being monitored. And most of the time, the labs do come back fine. So, I mean, we're not just giving you on the biologic and throwing you in the wild. We are we're monitoring that care. So, in terms of the emotional side, definitely we're here to guide you. We know the disease condition can actually impact your mental health. We know it can even impact you going out with your friends. Even sometimes if you're dealing with alopecia areata, you probably don't even want to come out your house. Like, where's my hair? You don't even want to come outside to say hi to the neighbor because you're like, okay, am I looking okay? So I mean, those things, the emotional toll that the disease can take, it's a lot. So I mean, just letting them know, we're here for you. We know that this is a chronic condition, but yes, there are several medications that can help control it. I mean, that's always beneficial. I mean, to the
Yeah.
patient.
I mean, part of your job is also that counseling.
Definitely. I say it's like dermatology therapy. There's
Yeah,
always some therapy session.
absolutely. I mean, there's so many different like you said, chronic conditions that really they have an emotional aspect to them. When people are struggling with these conditions because it does affect the way their appearance and how they look, but it also can affect internally how you handle a situation or how you go about your day or what jobs you choose to take based on what conditions you have, and that impacts everyday life, and it can be debilitating for a lot of patients. So, yeah, I mean, there's so much of the emotional side in there that it's hard to really to manage as a patient.
Yeah, it is. And just imagine even your skin. It's hard to hide your skin. Imagine having psoriasis all over your face.
Mhm.
How are you going to mask that? So I mean, those are things that you can. I mean, even with hair loss, you can mask it with a wig and stuff like that. But when it's actually on your skin, and people are like, "Oh, you have even kids." I have patients tell me, "Oh, my grandkid is the one that pointed this out to me," or yeah, because now you're cautious because other people are telling you, "What's that?" and they're looking at you weird. So it just puts you in a weird social spot. So yeah.
Yeah. I've been noticing, like, with access side, insurance has been asking more questions about, how it affects their day to day. So, is that something that you really kind of highlight in your documentation and making sure that they actually can see? Because I feel like that is one of the biggest things when it comes to access is that insurance companies, yes, they're looking at the information, they're looking at what the patient's tried and failed, but it's hard for them to see the human aspect, to see the patient. We see the patient, you see the patient and see what they're dealing with and how they're struggling.
Mhm.
But when you're submitting that prior authorization, it's so frustrating because it's like they're just looking at a paper and they don't see the patient.
Yeah, definitely. I always write extra on
Mhm.
my note. I always go extra. So even my patients with itch, like eczema, I ask them, "Does this itch keep you up at night?" I mean, those are just simple questions I ask. Does this keep you up at night? Do you wake up in the middle of the night just itching and unable to go back to sleep? I mean, that can impact the quality of life. So definitely, quality of life goes in there, and that can even push them from a mild to a moderate. If you have this patient who can't sleep because they're constantly itching, but maybe they don't have widespread rash on their body, that could probably bump them up to a moderate, and that could get them the medication that they're qualified for. So, yes, definitely. I do include quality of life on there because that should be part of the whole treatment. Yep. Mental, physical, all that. Yes.
Yeah. What do you think, a misconception that patients have about dermatology today?
I mean, most people think dermatology is all about, Botox fillers. I mean, wasn't now with the age of social media and we want that quick fix too. I mean, there's a lot of things going on too on TikTok where patients have like those acnes and they're like, oh, I've been using this product for 2 weeks. Now it's better. And I'm like, well, that's not how it works. If I start patients on acne treatment, I tell you, it might even take up to 6 weeks for you to start seeing any improvement. It can even take up to 6 months on a retinol to start seeing any improvement with your fine lines or hyperpigmentation. Yes, dermatology does take time. It takes consistency. You have to be consistent in what you do. So not just try a product for 1 week and then throw it away and say, "Oh, that wasn't working for me." I mean, except you're having like a burning in your face, then yes, it's not working for you. But when you've been using this medication now, because even on TikTok, there's different skincare products thrown at you left and right. And you see these videos of the influencers, using it like, oh, this how my face was before, now it's this. So I always advise people, get expert skincare advice. Not everyone has the same skin type. Whatever worked for person A is not going to work for person B. I mean, you want it customized to you and your skin specifically. So I mean that's the big misconception with dermatology. It's like, oh, I want a quick fix, or it's all about, all this pretty Botox and filler. Nothing wrong with that. But dermatology, as I said, immunology in action, it's a lot of immune stuff that we have to understand in order to treat a specific condition. Even acne even has an immune component to it as well. I mean, it's an innate immune component. But yes, these also targeting inflammatory markers that then causes the pimples and inflammation in your face. So understanding all this is actually how we treat it. So it's not just throwing anything we see on our face and then causing more harm.
Yeah,
Yeah.
absolutely. I know like you said, there's so much on social media now that it does make it so difficult because you get all these influencers that like to highlight products and people are watching this, especially our younger kids are watching this and they're like, "Ooh, I want that because so and so has it and they loved it and they said that it works great." And it's like, "Okay, but does that work for you? Do you have that exact same skin type?"
Yes, exactly.
Yeah.
Exactly.
But so you do a lot of teledermatology as well. So
Yes.
tell me a little bit about that and how do you like teledermatology? Because I feel like with dermatology, you have to be, like, looking at the skin, and
Mhm.
it seems like it would be a little bit more difficult, but obviously we see a lot of teledermatology all over now
Mhm.
since I wanna say since COVID probably.
Yes.
I'm sure it was before that, but now more so.
Yeah, I mean, the main thing is getting high quality photos, that's for sure. And it's not everything that we can treat via teledermatology. So I'm not gonna do a full body skin exam via
Mm,
teledermatology. I mean, we're thinking more of acne, melasma, hyperpigmentation, or even psoriasis of the scalp. I mean, things that are visual. I mean, dermatology is mostly visual and also a lot of good history taken. It's like, okay, when did this start? Was flaring it up and all that stuff. So, I mean, those are the conditions that work best for telederm. But if you have like an acute widespread rash, and then I take or I do a history and I find out, okay, this is probably not dermatology safe to do via teledermatology, I can definitely refer them to an in-person dermatologist as well. So it's not to replace our traditional dermatologist, but it's actually to create that access of care. As you know, with wait times with dermatology's office, you probably don't want someone with an acne that is going to scar up and leave hyperpigmentation. And then those scars are very difficult to get rid of. And insurance most times don't pay for microneedling or all those cosmetic stuff needed to help with those scars. So, I mean, the earlier is treated, the better. I mean, most of my patients now on acne treatment, I have few on isotretinoin who have been dealing with acne for a long period of time and even having scarring. So those are things that I feel like, yes, they're actually very telederm appropriate and just creating access to care. And it's weekend, so which is even better, right? Because most time most people can take off work to go to their doctor's appointment and you do it from home. You don't have to drive. I mean, that's just the way I like it.
It makes sense, because there's so many offices that are just backed up for months at a time.
Mhm.
So it's like, when you get into that appointment finally, it takes forever to get in there.
It does. And not only that, it takes forever, and then when you get in there, most of the time you're being seen for, like, what, 15 minutes?
Yeah.
And most people feel like, "I feel like I'm not being heard," or "I didn't have enough time." Good thing I do spend 30 minutes with my patients initial visit, but for follow-ups, yes, it is 15 minutes. But, yeah, I think most clinics do for new patients, they actually spend a little bit longer
Yeah.
as well. But, I
I'm
mean,
sure
just
it happens
having that.
too, is that you have that more time
Mhm.
with teledermatology to actually spend with the patient and kinda talk to them.
Yeah. Yeah, so I do like that time, gets history taken. I mean, well, not just medication, you want to find out what they're actually doing, what products they're using, how's their diets like, all that stuff that, the holistic care of treating a patient is addressing all that. So
Yeah.
I do like
Do you
that.
feel like there's any challenges with teledermatology at
Yeah,
all?
definitely. I mean, our older population for sure,
Mm,
we're not tech savvy. mm, Will probably prefer an in person. I do have some conferences that I go for here, and most of the women there are like, "Oh, do you have an in-person clinic?" They want to be touched, and they've actually complained that they go to a dermatologist's office, no one's touching their hair, no one's touching their skin.
mm,
And that complaint is like, okay, they want to be touched, like you care.
mm,
The touch is like, oh, you care. You actually are concerned about what's going on in their skin. And that touch is missing from Telederm.
yeah,
Yeah, yeah. So, I mean, that's why I said it's not for every skin condition. But that's probably the con of Telederm, I would say, is that having that touch. But also, there are patients that will work for because they're patients who don't want to leave their house because of this disease condition. They don't want to go see the front desk person and then go sit in the waiting room and have 10 different people staring at them and go in there. That anxiety also towards healthcare. And not only that, you already feel depressed because you're having this skin condition. So, I mean, you tend to bypass all that because now you're in the comfort of your home
mhm,
and you're seeing the provider. But
yeah.
in terms of the touch, it's not there. It's not there with the tail.
It's interesting. I never thought of the touch being
Mhm.
something that patients actually really want.
Yeah. And it's part of even our nursing care model. Like, touch is part of the care that you give patients. It just shows that you're concerned for them. And yeah,
That makes sense, though.
yeah.
So when people are going to book their appointments, is there like a list on there that says, "Hey, this is what we can actually treat, and these are some of the things that you actually should come in person to see the dermatologist for?"
Sure. On the website, there are a list of conditions or services that we provide, which includes the acne, hyperpigmentation, seborrheic keratosis, even psoriasis on there. If you want like a skincare guide, also it's on there. If you have like an acute rash, like maybe you had a poison ivy, and you definitely know what that is. Yes, so Telederm will be appropriate for you. Skin concern, usually it's all cash pay, so it's about $100 for that initial visit. But if you have like a chronic condition like eczema, because we do want to spend more time with our eczema patients in terms of guidance on is this irritant, because there are also other things that could cause you. Is it an irritant contact dermatitis? Are you allergic to something? Is this actually eczema? So most people see all the rash and they're like, "Oh, it's eczema." It may not be eczema. So usually you want to spend more time with those patients. So those ones are what I call like advanced visits. So they're a little bit longer and more expensive. But yes, I do list all the services that we do provide on the website. It's right there, dermernp.com. So all the services are on there.
Nice. Okay. Well, we'll make sure that we put that in the, show notes as well,
Sure. Thank
so people
you.
can find you as well.
Yeah.
So, tell me a little bit about what your plans are for future, because I know um, you grew up learning.
Mhm.
Is that something that you are interested in doing, or are you doing that right now as far as, like, just teaching? the next generation?
Yeah. So, I mean, what's exciting at my current job, I do teach the NP residents, like dermatology, hands on, suturing, just identifying those common lesions that you see every day in the clinic. And also feel free to, use your resources, consult with your dermatology provider and say, hey, I mean, our system where I work, there's a closed knit. So you can just Teams message and say if you want something, or you can do an e-consult as well. But just getting, and those are primary care NP residents. So just getting them comfortable with skin conditions is actually what I do love doing. My spare time also, I do like to speak with the Black Women Conference and just share some of my knowledge, some of the misconceptions, in the Black community around skincare and just, educating the public because we still do have that. There's some misconceptions that we shouldn't use sunscreen. The misconceptions about even our skin exam. I mean, there's still disparities in healthcare. I mean, they're not gone. We still have melanoma. We have a cure rate of melanoma now at 90%, but also for Black patients, it's about 70%. I mean, addressing those gaps and saying, hey, you still have to do your skin exam every month, self skin exam. Anything new, anything changing, any chronic wound that's not healing, you probably want this addressed. You have We have patients that will be on Neosporin for a year, over the counter Neosporin. They're like, I've been using Neosporin on it and it's not getting better. And it's a year after. And you're like, well, I say, anything that's not healed in 8 weeks, come right in, come right in. So, I mean, just giving them those, advice and just letting them know that I'm actually always there for resources, questions that they can ask me, or direct them also to an in-person dermatology provider that can actually assess them and just giving them the resources around their community is actually helpful. So, that's what I do love. I do love doing that. I also, because I've been working with a lot of older population, I've seen the importance of teaching them young. So even in my other private dermatology practice I was working at, I saw a lot of kids as well there.
Mm.
And now even seeing older population mostly, and most of the time it's like they're like, oh no one ever told me to use sunscreen. We use the baby oil and all that stuff. But I mean, it's also what was present back in the day and what was common, known. And even some people are like, "Oh, no one told me to use a moisturizer." I'm like, okay, yeah, now my skin's dry. So I mean, teaching people young how to take care of their skin, I think it's empowering. Actually, I've not officially announced it yet, but I'm just gonna say I'm actually writing a kid's book that's gonna be published soon here.
That's exciting. Congratulations.
Thank you. Thank you. So I thought I was like, oh, this is very important for me to put in a kid's book. I mean, all the things skincare related. It's actually Skin for Kids. That's just the name, Skin for Kids.
I love that.
Yeah. So that'll be coming up here shortly. Hopefully in this summer, it should be coming up. But yeah, I'm actually excited about it. I actually had the proof. I read it to my kids already and they love it. They're like, oh, read it again, read it again. I was like, I've been writing this for a year. I have read it 10 times or more, over 100 times through the editing
Right, but
process.
does it resonate? That's the thing.
Yes, it does.
That's great that
Even my editor was like, you know what? I think I should go put on some sunscreen now. I was like, oh,
see, adults can
the
learn from it
job's done.
too. Right. That is so good. I love that. You know what? It is so needed. I think about that a lot too. And, this younger generation, they're so connected to technology that, we want them to understand how to take care of their skin. And, you said something earlier though that I thought was really interesting
Okay.
when you said you talk to women about their skin and how, using sunscreen and when to get their skin checked. Where are they getting a lot of their information? Like Black women in general, where are they getting like just their understanding of how to care for their skin?
So no, I don't know. I think it's probably maybe from family members,
Mhm.
generation. I mean, from generation to generation, like, "Oh, use this." I mean, we love our cocoa
Yeah.
butter and all that, but sometimes even cocoa butter can be comedogenic. So if you do have acne that's all over your face and you're rubbing that cocoa butter on there, you're probably even blocking your pores more. So even understanding, okay, maybe I should switch to a shea butter, which is probably lighter. Or even now that it's summer, maybe I should do a shea butter. Now that it's winter, maybe I should do cocoa butter on my arm because it's thicker and that can prevent me from being ashy and all that. But I think we learn mostly from, our moms and dads from generation. There's also Facebook groups that have tried to infiltrate that are
Yes.
like holistic Facebook, but sometimes I just go there and I keep turning my head. I'm like, oh no.
I
I
mean,
just put all the
totally
advice on there and I'm like, oh.
love that you do that because that's something that I would do. I'd be like, I just want to see what they're saying.
What's going on in the streets. Exactly.
Man, that is hilarious. I
So
love that though.
I do that, but I'm like, I just try not to say anything. I'm like, oh no, don't say anything. I'm like, yeah, because I can give medical advice online and all that. But it just makes me identify the gaps that are present
Mhm.
because that's where people are getting the information from. They're asking people on Facebook who have no clue about their history, nothing like, oh, what
Right.
is this rash? Oh, what should I use? And you see all the comments like, oh, use some tea tree oil,
Right.
do some parasite cleanse. Because parasite cleanse
It's
is
the cure for
is
everything
the
right
cure
now.
for everything.
I know, it's like you see one little video and all of a sudden everybody has their remedy for a parasite cleanse. You've got parasites if you've got a little dot on your face and yeah, oh, you're
Yeah, but funny enough, some parasites like rosacea, we do have, we have Demodex. I mean, that's that's the one I'll be concerned about. But when you talk about the whole cleanse, like flush your system and all that, I'm like, well, not really for this condition, but
I
okay.
mean, the idea that there's some internal changing that needs to happen for your skin to become clear, I
Mhm.
get that side of things,
Yeah.
but when you're yeah, getting too
Mhm.
much information online,
Yeah.
it can be detrimental.
It
But I
can.
love that you're doing that kind of education but just education in general to people, I think is so needed because we have so much information and being able to find out, okay, where can I get real information that is, by somebody who actually understands and that is there to really help support and take care of patients. I think that is huge
Yeah.
and that is so commendable.
Yeah, thank you. I do appreciate that. Yeah, I definitely think so too. Even the simple things as even choosing the right sunscreen.
Mhm.
Yeah. So, I mean, I tell them like you have to make sure it's broad spectrum, protects you from UVA, UVB. And if you're concerned about hyperpigmentation, definitely that UVA, that visible light protection as well. You want to protect yourself from that. So, yeah, it's just those simple things and yeah, educating patients on it. Yeah.
So, I'm gonna ask you, what is your favorite product right now or your go-to well, I guess we could start with sunscreen.
Well, my favorite product actually is not even the most common ones. I like the Think. I think it's called Think Daily is the name of the sunscreen. It's actually tinted sunscreen. I'm gonna look it up. I think it's Think Daily. Yeah. Think Daily tinted sunscreen. I do like that one very well. I mean, it's the zinc oxide, so definitely protects you from that visible light as well. And if you're concerned about hyperpigmentation, and it actually looks well on my skin. Another one I do like is the La Roche Posay. I actually have it here because I have the sample size. So this one actually works very well. I actually have it on, and it doesn't like leave that that wide cast on my face. So this one is actually, and this one is SPF 50. Usually I say 30 above is great, is good, but most people don't apply enough because technically you should apply like your full length of your fingers on your face and then full length on your neck.
I didn't realize it was that much.
Yeah.
I don't think that's a lot.
See, that's a lot. Just imagine you put in that white one and you're doing the full length. It's
Yeah,
like you're never gonna blend that in.
no.
You're gonna be on there like rub it. So I do like this one because it actually does that. Like it blends really well. So like full length, like all the way, and then on the two fingers actually. And this one is actually really good. You can see how that
Yeah.
even gives me a glow. I'm like, yeah, I do like this one.
Okay.
And they always say, the best sunscreen is the one you're gonna use as well. So, I mean, if you try to protect yourself from visible light, of course,
Mhm.
use the tinted one. But I mean, if you're like, oh, I don't really like it, you probably won't use it as much. So just get the one that you know you're gonna
I
use.
do love a tinted sunscreen.
Hmm.
I
Yeah,
think
because it
that
has that
yeah.
pigment to it, and
It
that's the
doesn't
one that
waste.
actually helps with the hyperpigmentation because it has the iron oxide in it that has been shown to help.
Oh, that's good to know. I was always wondering though, does because they have the tint in it, does it make it less, I guess, potent than a one without a tint?
No, I don't think it makes it less potent. There are even ones now that are tinted that are even SPF 50 or greater. So not really. You just want to look for the SPF factor. I think they pretty much have the same
Yeah,
strength. Yep, if not better.
that's
Yeah.
awesome. Well, this has been so helpful, and
Oh,
I
good.
love being able to just share knowledge and just share some education, with so many people because I think immunology is really cool. Well, dermatology is cool in general, but being able to kinda do a little bit more of a dive into the immunology aspect so that people can understand it a little bit better, I think that is so helpful because we are so quick to just hear, oh, you have this chronic condition or you have that, and you don't really understand fully how it affects your body internally and what exactly that means and autoimmune condition. So I love how you explained it and I love that you created this kids book. That is awesome. I am like I can't wait for this to come out.
As soon as it's out, I'll share the link on where to
Yes,
get it.
absolutely. We'll be looking for that.
Thank you.
So, but thank you so much for joining me, and this has been so much fun to chat with you.
Thank you, Janelle. It's been so much fun having or being here. Thank you.
Thanks for spending a few minutes with me and listening to That's Derm Good. You can expect new episodes of That's Derm Good every week. The podcast is available on your favorite app, including where you're listening right now. Subscribe to the podcast so you never miss a new episode. Bye.